Good afternoon. My name is Shelby Esselman. Welcome to this presentation to introduce the troponin protocol training for paramedics. The purpose of this presentation is to provide a brief overview of the protocol and planned training methods for implementation. Healthcare professionals have an ethical duty to stabilize, assess, and treat the 7 to 9 million patients who present to the emergency department annually with chest pain. High sensitivity troponins, or HSTNT results, are a critical component in stratifying risk for these patients and identifying an accurate diagnosis for application of an appropriate clinical decision pathway. Underperformance at 73 minutes in current troponin turnaround times prevents the provision of efficient care and is negatively impacting the discharge and ST-elevated myocardial infarction, or STEMI, performance composites that are reported to the Centers for Medicare and Medicaid Services, or CMS. The goal for troponin turnaround time, established by the American Heart Association, or AHA, and the American College of Cardiology, ACC, is 60 minutes. Supported by data from the ACC, the purpose of this policy is to implement point-of-care testing by emergency medical services en route to the ED to achieve compliance with this benchmark for the purpose of maintaining chest pain accreditation and improving patient outcomes. The ACC supports the implementation of physician-based assessment and decision protocols such as the Henry Ford History, ECG, Age, Risk Factors, and Troponin, or HEART, score, and provides evidence to support the addition of point-of-care testing for troponins by EMS paramedics en route to the ED. These protocols have been implemented successfully in other facilities and have been shown to improve the efficiency of care and the timely discharge of low-risk patients through presentation with completed HEART score upon arrival to the AD. Based on the completed HEART score, EMS providers will be able to implement treatment pathways such as aspirin administration and intravenous access en route and can transport patients to the appropriate chest pain accredited center. For low-risk patients, discharge can be initiated within 1 hour after the second troponin, freeing up valuable space in the ED and protecting the low-risk patient from misdiagnosis and overtreatment. Considering that 60% of chest pain patients arrive via ambulance, the implementation of EMS assessment pathways represents a significant opportunity for metric and outcome improvement. Admission to the ED is required for risk stratification for chest pain patients and frequently involves extensive, prolonged, and expensive resource expenditure. A traditional assessment in the ED encompasses a history intake, physical assessment, and correlation of troponin results. Based on this initial assessment and stratification, patients are categorized as low, moderate, or high risk and are treated accordingly based on the clinical decision pathway. Initiation of a completed HEART score through troponin point-of-care testing en route to the hospital has been shown to expedite the stratification pathway for chest pain patients significantly. This has been directly linked to improved door-to-intervention times as well as improved efficacy of discharge for low-risk patients. Plan, Do, Study, Act, or PDSA cycles are evidence-based methodologies that are useful in testing change and identifying barriers to implementation early. Utilizing PDSA methodologies in conjunction with simulation scenarios have been shown to improve training through enhanced learning and early assessment. The process starts by establishing a plan for implementation and outlining specific training needs identified for each stakeholder. During the Do phase, simulation has been shown to be an effective tool. Data is collected as stakeholders engage in hands-on training and apply the new process. Predetermined metrics or performance measures are utilized to study the results to determine whether the new process is effective in achieving outcome goals. The team can then synthesize data collected in each phase to act and remedy any barriers to success. HSTNT levels are of paramount importance in risk stratification for acute coronary syndrome, ACS, and diagnosing ischemia. Implementation of EMS-led point-of-care testing for troponins has been shown to improve outcomes and performance metrics as indicated by alignment with national benchmark data. Early indications of successful implementation will be evidenced by troponin turnaround times of less than 60 minutes and discharge of low-risk patients within the first hour after the second troponin has been interpreted. These indicators support standards from CMS based on evidence-based practice metrics developed by the ACC and AHA. Inefficiency and delays in care not only negatively impact direct patient outcomes, but exacerbate congestion and healthcare costs in acute care departments. Chest pain patients account for 10% of ED admissions, pose the potential to negatively contribute to EVD overcrowding if they are not processed efficiently, based on established clinical decision pathways. This leads to delay of treatment for other patients and increased cost, as well as poorly impacted outcomes and delay of elective procedures, EMS offload, and delay of subsequent EMS response times. The ACC asserts that improvements in the application of chest pain protocols mitigate the negative effects of inefficiency, improve performance metrics, and improve outcomes. The application of clinical decision pathways and rapid assessment protocols for low-risk patients represent additional complexity that must be considered. This patient population is at risk for missed major adverse cardiac events, or MACE, a risk factor that continues to be a leading trigger for malpractice claims nationally. For moderate to low-risk patients, risk stratification involves consideration of the risk-to-benefit ratio. Often misdiagnosis and overtreatment pose a greater risk than the potential for MACE. The Institute for Healthcare Improvement asserts that excessive testing increases exposure to radiation, increased cost, anxiety, and false positives. Falsely positive results are significant because they may result in unnecessary percutaneous coronary intervention or coronary dissection in addition to associated expenses. Emergency departments are legally obligated to assess and stabilize patients who are admitted with chest pain. As the stakeholders who identify risk, diagnose, and identify interventions, ED and EMS providers are ethically bound to demonstrate beneficence through the application of evidence-based protocols. Evidence-based clinical decision pathways and protocols are utilized to stratify risk for these patients and provide proven standards of care. Validated by the ACC and AHA, these protocols help to reduce the missed MACE rate. According to data provided by Henley et al., a missed MACE rate of less than 1% is an acceptable measure. The ACC supports the implementation of physician-based assessment and decision protocols such as the HEART score in conjunction with point-of-care testing for troponins by EMS paramedics. These policies have been shown to improve outcomes through the timely delivery of care and discharge of low-risk patients. Gaps in effective communication and a lack of established workflows have been cited as barriers that must be addressed. Responsibilities must be delineated clearly, utilizing the HEART clinical decision pathway as a guide. As first responders, EMS providers must clearly understand their role to assess and stabilize patients rapidly, providing the completed HEART score to the ED provider upon arrival. Pre-notification of the score by EMS expedites the offloading and initiation of treatment. Standardized report and handoff tools have also been shown to expedite this process and improve the quality of communication. ED providers must receive this information and be prepared to diagnose and treat patients accordingly, or discharge low-risk patients after a second negative troponin. Of the 7 to 9 million patients that present to the ED with chest pain annually, less than 10% are diagnosed with acute coronary syndrome. Troponins are a critical component of the diagnostic pathway. Considering the current benchmark shortfall in troponin turnover times, emergency care providers are ethically obligated to identify pathways for metric improvement to improve patient outcomes. In addition to poor outcomes, sustained underperformance may result in a loss of accreditation, reimbursement, and legal recourse. As the stakeholders who are directly involved in the care of chest pain patients, ED and EMS providers are poised to make a positive difference to improve outcomes. ED and EMS providers must establish a collaborative partnership and streamline the workflows and implement communication and clinical decision pathways together. As stakeholders in this policy, cohesive engagement is critical to the strength of implementation and overall success. Research supported by the ACC has demonstrated safety in EMS-initiated rapid pathways, yet effective implementation has suffered inconsistent success. Vision for this implementation project is to promote positive patient outcomes as evidenced by improved STEMI and discharge performance metrics and reduced missed MACE rates. The most recent STEMI performance composite percentage measured at 92.6% and discharge performance had dropped to 86.6%. ED and EMS providers will contribute to this endeavor directly through the implementation of point-of-care testing for troponins, enabling ED providers to initiate timely intervention of discharge based on complete heart scores and evidence-based risk stratification. A simulation-based training framework will be utilized for implementation. The steps involved in this framework are to learn, see, practice, prove, do, and maintain. The Learn component will include a PowerPoint presentation regarding application of troponin results to the diagnostic protocol. It will also include a presentation regarding point-of-care device operations. The C component will be comprised of a step-by-step demonstration of point-of-care testing device use by a super user. Trainees will then practice use of the point-of-care testing device and will prove competency through demonstration of independent use and a comprehensive exam. Learners will then integrate point-of-care testing into their practice and do testing regularly. They will maintain proficiency through continued use of this device and annual competence. This method is evidence-based and effectively incorporates didactic, hands-on, and competency-based learning techniques. This training method addresses clinical aspects of policy implementation as well as technical. Thank you so much for your time today. I appreciate sitting with me while we overview our training protocol and what we have in place so far. At this time, I'll entertain any questions that anybody has. Thank you so much.